Good morning, everybody, to all the judges and my colleagues sitting here. I'll be talking about double-stage flap procedures for eyelid reconstruction in a case of a meibomian gland carcinoma. I would like to thank Dr. Saptagiri sir for giving me this case. So, meibomian gland carcinoma has a propensity to mimic multiple eyelid conditions like chalazion, basal cell carcinoma, squamous cell carcinoma. Aggressive diagnosis and multimodal surgical treatment helps to tackle this condition and give patient a good cosmetic as well as a functional outcome. So, reconstruction challenges. So, in our case, it was an upper lid meibomian gland carcinoma, and for upper lid, it plays an important role in maintaining the ocular surface as well as it gives a structural rigidity and stability to the eyelid. So, if the size of the defect is less than 1/3, it can be closed directly if the lid laxity allows. But when they are bigger than 50%, flaps and grafts will be needed for reconstruction. So in a present case scenario, we did something called as a modification of a Cutler-Beer technique. So what is a Cutler-Beer technique? A Cutler-Beer technique is used for an upper eyelid defect in which we use only the myocutaneous flap from the lower eyelid is transposed to the upper eyelid. But in modification of Cutler-Beer technique, which I will be telling in my case, so our case was a 58-year lady with a right eye upper lid swelling since past 3 months, which was gradually increasing in size, was associated with pain and bleeding, especially when she rubbed her eyes, and the visual acuity in her right eye was 6/36, whereas the visual acuity in her left eye was PL positive as she had pseudophakic bullous keratopathy changes. So this is the presentation. There was a full thickness lesion extending from the medial canthus to the lateral canthus with lid margin involvement, loss of hair follicles, and mild lag of thalamus was there. Management, what we did was that initially we did an upper lid full mass excision and the specimen was sent for histopathological evaluation. Histopathological evaluation showed an intraepithelial and focally invasive meibomian gland carcinoma. Following which we did a reconstruction of the defect with the help of an forehead Frick's flap. The anterior lamella was reconstructed, and for posterior lamella we used the donor sclera. So this is 1 month post-operatively. The patient presented to us. The cilia of the forehead flap had overgrown and they were rubbing the cornea, leading to corneal exposure changes. And as this was the only seeing eye, as you can see in this case, there is a lateral pedicle graft and corneal exposure changes. So as this was the only seeing eye, we had to do a lid sharing procedure. That is, we did a modification of Cutler-Beer technique. As we know, in a Cutler-Beer technique, only the myocutaneous flap is used, but in this case, we used the tarsoconjunctival flap of the lower eyelid. So what we did is that we took an incision in the lower, first we took a lid margin incision in the upper eyelid, and then we split the anterior and the posterior lamella. In lower eyelid, 2 mm below the lid margin. In ideal Cutler-Beer, it is taken 4 mm, but in our case, we took it 2 mm below the lid margin. We separated the anterior lamella and we separated the posterior lamella. The tarsus and the conjunctiva of the lower lid was opposed to the tarsus and the scleral graft and the that is the posterior lamella of the upper lid with the help of a 6-0 vicryl suture, and similarly the anterior lamella were also sutured. So this was the patient achieved there was a closure for at least 6 weeks. We didn't do the flap division procedure, and after 6 weeks when we called the patient, we did a flap division procedure, and the patient achieved the adequate lid contour and there was no lag of thalamus. So the discussion is that the modified Cutler-Beer technique. So why we didn't go initially with the Cutler-Beer technique? Because the patient had only seeing eye. So we wanted to prevent a flap procedure as it will cover the eye of the patient and will obstruct the vision. But that's why we initially did a forehead Frick's flap. Then as the cornea of the only seeing eye was getting compromised, we did a modified Cutler-Beer technique in which we used an anterior lamella which was reconstructed by using a lower lid skin and a pedicle flap, and the forehead and the posterior lamella was with the help of the lower lid transoconjunctival flap. So this technique of modification of the cutler beer, it gives a rigidity to the upper eyelid, and thus not only helps to maintain the structural support, but also helps to give a better functional as well as a cosmetic outcome. So it allows for a complete reconstruction of the upper eyelid defect with required rigidity and support. I would like to thank everybody for this.
Thank you, Dr. Ashwini. I just have one question. Did you do a frozen section when you did the first excision? How did you determine marginal clearance?
So initially we did a 2 by 20 millimeter excision of the mass, and then we gave it for a histopathological evaluation, and it showed that the margins were infiltrated. After that, a wide excision of this, again the patient underwent a wide excision procedure in which almost like 80 to 90% of the lid was excised. Beyond the pre-existing defect. So almost like 35 millimeter of excision was done, and that specimen was sent for histopathological evaluation, and then it showed margin clearance, and after that we did a forehead pedicle flap.
Did you do any conjunctival map biopsy? Considering the extensive involvement of the complete eyelid, did you do a map biopsy of the conjunctiva to check if there's any, because you know maybe only customers can have skip lesions and everything. Was a map biopsy?
No, sir, we didn't.
No map biopsy was done. Because almost the whole lid is involved.
Lid is involved, yes. We didn't.
So when did you do the second sitting of excision of the?
So immediately after we got the specimen.
4-5 days or?
1 week later, sir.
So for 1 week, patient had no upper lid. It was completely exposed.
Yes, sir. Like for 1 week we had called her back, as this is like camp patients. She came back.
How did you protect the eye 1 week without an upper lid?
So we gave lubricating eye drops, and we told her to come back immediately after 2 to 3 days. But the patient, she came little bit later. So following that, when we got the histopathological report, we immediately took her for the remaining margin clearance.
Another thing, the modification, usually we advise not to make any incisions very close to the lid margin, especially in the lower lid. Number one, you can get ischemia. Number two, you can have loss of hair follicles. All the hair follicles will go. So that's why you make it a little bit lower,
yes,
so that for a standard cutler beard,
yes,
so that you have a vascularized pedicle, which will take up well. Make it very close to the lid margin. You can have a lid margin necrosis in the lower lid. Hair follicles, of course, will all go.
Yeah, correct me if I'm wrong. My understanding of the cutler beard procedure is a condition where you have a composite flap which is derived from the lower lid, which includes both the anterior and the posterior lamella. So where is this modification that you're talking about?
So in cutler beard technique, we use only the myocutaneous flap of the lower lid.
I mean, that is not the way most of us understand the cutler beard procedure, right? It's a composite flap, both posterior and anterior lamella.
One more thing, how many surgeries the patient has undergone?
Ma'am, 3 procedures.
If you had calculated the measurement of the frontal flap, it could have been done in a laser surgical procedure, don't you think so? But see, once you have done the forehead, this could have done with the cutler bead itself instead of doing the frontal flap.
Ma'am, the patient only had, it was a only seeing eye.
Right.
So we didn't do the flap procedure.
And you left it unprotected for 1 week?
No, sir. Yeah.
Interesting choice.
1 week complete no upper lid, the chance of corneal exposure is far greater. Actually, if you do a cutler beard flap, cornea would have been safer actually.
Yes, sir. But
anyway, it's a novel experiment. Congratulations. Thank you so much for your excellent presentation.